Hi, everyone. I know we may still have a few people logging in, but we wanted to get started. Thank you all for joining us for the second webinar in our didactic series presented by the Functional Neurological Symptom Disorder, SIG. We're very excited to have Dr. Phobien here with us today. Before we move into Dr. Phobian's presentation, just wanted to give you all a little bit of a heads up about some things that the FNSD SIG is working on. For those of you who are not a member of this SIG, we encourage you to join. We are working on developing two directories, one for treatment providers who work with youth with FNSD, as well as a directory of training programs that have some type of emphasis on pediatric FNSD. So we have two surveys we've created. If you are a clinical provider who works with youth with FNSD, we encourage you to fill out our treatment survey if you haven't done so already. And then if you are a training program that offers opportunities for trainees to work with individuals with FNSD, we encourage you to complete our training survey. So if you've already completed those, thank you so much. We really appreciate it and encourage everyone who hasn't done so to please go ahead and use the QR codes to pull up the links to those surveys. Okay, looks like people have kind of slowed down entering in, so I'm going to turn things over to Dr. Phobien. So we are very excited again to have Dr. Phobien here today to present on retraining and control therapy, or ReACT, for pediatric functional neurological symptom disorder. So Dr. Phobien is an associate professor and clinical psychologist in the Department of Psychiatry at the University of Alabama at Birmingham, where she is the PI of the Functional Neurological Disorder and Pediatric Behavioral Health Laboratory. She obtained her PhD in clinical medical psychology from the University of Alabama at Birmingham in 2013 and completed her clinical internship at Baylor College of Medicine in 2013. And her psychology postdoctoral fellowship in the Leadership Education in Adolescent Medicine, or LEA program, in the UAB Department of Pediatrics in 2014. Dr. Phobien's research aims to develop and disseminate evidence-based behavioral health interventions, including for FND. She developed ReACT, or Retraining and Control Therapy, a behavioral health intervention for FND, which she's going to present on today. And she's currently conducting two NIH-funded studies on ReACT. One is a mechanistically funded NIMH-funded study to confirm the treatment targets by which ReACT is effective, and a NCCIH-funded multi-site feasibility trial with Yale University and Baylor College of Medicine in preparation for a large efficacy trial. So I'm going to turn things over to Dr. Phobien.
See if I can unmute. Thank you so much. So thanks for having me. I'm excited to talk about this. All right. See if I can get it to cooperate. Here we go. Okay, so I have no disclosures to report. And so what we're going to talk about today will be targets of treatment for pediatric FND. So this is some of the research that Dr. Thompson just mentioned, where we're looking at mechanisms by which treatment works so that we can enhance that treatment, and it helps sort of understand why we do react the way we do. We're going to talk a little bit about healthcare-related stigma and discrimination experiences for children with FND. We'll talk about ReACT and then discuss ways that you can use ReACT when you're seeing patients. So, as most of you probably know, FND is the second most common diagnosis in outpatient neurology clinics. There's not a lot of attention, or, there really wasn't much research on FND until about the last 2 decades, but it's a really common disorder and can be very debilitating. And so Dr. Nicole Zaka and Dr. Laurie Thompson both talked about this a few months ago and did a great job. So I'm going to skip a lot of the intro to FND so that we can get to treatment. Just as a brief overview, the DSM-5 TR criteria include neurological symptoms, So it looks like seizure-like attacks, paralysis or weakness, tremors and tics, vision loss. It's really common for patients to have mixed symptoms, a lot of different symptoms. And really now the DSM-5 moved the diagnostic criteria to be a rule-in. So instead of being a diagnosis of exclusion, you really have to have signs and symptoms that rule in FND and that are incompatible with symptoms from other neurological or medical conditions. So there's a lot of heterogeneity, again, already covered, but a lot of predisposing factors to FND for, psychiatric comorbidities and trauma history are probably the two that are the most commonly talked about. Bullying, learning disabilities, neurological comorbidities, family stress. And so again, looking at trauma and psychiatric symptoms, which has been that long believed explanation, or really the main explanation for what causes FND is that, it's stress, or it's a history of trauma, or some underlying something that you're not aware of. We took adolescents with functional seizures and we matched them very closely based on age, race, sex, and family income. And when we did that, we did the MACI, so we're looking at maladaptive personality traits. We looked at the BAS2, so internalizing and externalizing symptoms, and then the CTQ, childhood trauma questionnaire. And so of all of this, when we compared kids with functional seizures to match controls, only thing that was significant was somatization. So just other somatic complaints. That doesn't mean that these patients may not have anxiety or depression. These T-scores here are very high, 80s and 70s. But when you look at the match controls, they have anxiety. Some of them have anxiety and depression too. Same thing down here with the BAS. So these patients may have anxiety and depression, but we know that treating mood really is not very effective for the treatment of FND. So the only really large, well-powered trial that we have of FND, period, it was done in adults. It's called the CODES trial. It was done in the UK. And so they compared CBT, which really targeted anxiety and fear avoidance, and they compared that to just, standardized medical care, treatment as usual. And so they had 368 patients, half received the CBT and half just the standardized medical care. And at 12 months, they had no difference in seizure frequency. Both groups improved. They had improvements in secondary outcomes like quality of life, but really want their functional symptoms to improve. And so targeting mood, something like fear avoidance or anxiety, is not necessarily helpful for the functional symptoms. Additionally, there have been placebo-controlled trials in adults of medication. So comparing sertraline or Zoloft to placebo in adults with functional seizures, and sertraline did not result in a significant reduction in functional seizures, even though it did improve anxiety and depression. So targeting psychiatric comorbidities is not going to be helpful for FND symptoms. And really, those psychiatric symptoms, maladaptive personality traits, and trauma are probably just not unique to pediatric functional seizures, despite that ongoing belief that that is one of the main reasons that FND is triggered. So briefly, we're going to talk about a few of the other possible targets. If we're not going to target mood, what should we target with our treatment? So one is symptom expectations. So that's something else that's been found to be really common, abnormal symptom expectations for kids with functional seizures. So when we think of symptom expectations, a lot of times we think about the conscious expectations, like a placebo effect. So, you're told that you're going to take a pill and your right arm is going to be numb. You take the pill and your right arm feels numb. And so that often has a stigma around it as well, like that's not really true. However, they have functional MRI, like fMRI correlates with those. So those are not faked or just something that they believe. They actually have functional correlates that occurred with those placebo effects. Additionally, we talk about preconscious expectations. So these are these predictive models of brain function, like Bayesian statistical modeling. And these influence all of our motor and sensory perception. So for example, if we look at this video, so we have this little mask of Einstein. And so it's going to start rotating. And as it rotates, all of a sudden you realize you were looking at the inside of the mask and the concave portion of the mask. Now, you know you're looking at the convex part. It's rotating again, you're about to look at the inside. You know you're about to see the inside, but all of a sudden your brain perceives that as the convex, the outer portion of that mask. And so even though we know we are looking at the inside of the mask, you're not perceiving that to be the inside of the mask. And those are predictions that our brain makes without our control. And so these kind of preconscious expectations can create the functional symptoms that we see with FND. So another is attention symptoms. So this is another common predisposing factor that's found. And so we looked at this mainly reported in adults. And so we looked at this in children. So we compared 22 children with functional seizures to match controls, and we did the Stroop, a modified Stroop task. So y'all are all familiar with Stroop probably. So you have the congruent condition where they have to say the color of the word, but the color matches the word itself. You have the incongruent condition where the color doesn't match the word. So they should say blue here. When the word is red. And then the third condition was a seizure symptom condition. So where they would see words like unconscious or shaking that describe seizures. And they would have to tell you what the color of the word was. And so again, this is on a computer, so they're pressing 1, 2, and 3 to be able to pick that. And we're looking at reaction time. How fast can they tell you the color of the word? And so, this is looking at cognitive inhibition and selective attention. So can you selectively attend to the information you need and inhibit the information that you don't? And so you would really think that in this condition here, with it being a seizure word, you're looking at the color, there should be less interference than up here with the incongruent condition, because the color of the word and the word itself are related, and here they're not. So when we compared the kids with functional seizures with matched controls, the reaction time, the kids with functional seizures had a slower reaction time in this seizure word condition that was more similar to their reaction time or response time in the incongruent condition. But for the match controls, the seizure word condition was more similar to their congruent condition. And so this suggests that kids with functional seizures don't have an overall impairment in cognitive inhibition and selective attention, but when they're exposed to physical symptoms, seizure symptoms, they have difficulty with attention and cognitive inhibition, the match controls. The third one we're going to talk about is sense of agency or sense of control over symptoms. So there's a lot of fMRI data in adults and in children that have demonstrated impairments in sense of control or sense of agency over symptoms or over movements. My favorite one was done in adults who had an episodic hand tremor. And so they put them in the scanner when they were having the episodic tremor, and then they put them in the scanner again when they were not having the tremor, but they had them mimic their tremor. And so what they found was decreased hypoactivity in the right temporoparietal junction and lower functional connectivity between the right TPJ and the sensory motor cortices and limbic regions during the functional tremors. And so basically all of the motor regions of the brain were being used, but this connectivity between those areas is what's associated with your sense of control, your sense of agency over those symptoms. And that was impaired despite using the voluntary motor pathways. So the use of the voluntary motor pathways is there, they just aren't perceiving that. So that could be, again, something that we can target. So we looked at this in kids with an experimental task. It's this very 80s task where the X's and O's fall. And so they use their cursor and they move this little white box to try and catch the X's and miss the O's. And so there are 4 conditions. There's a normal condition where nothing is manipulated. And then there are 3 conditions where their control over the cursor is manipulated. So there's a normal there's a turbulent condition, which I think is the most obviously manipulated, where when you move it, it vibrates around and just sort of has a mind of its own. Has a lag condition where it has just a few millisecond lag. When you move it, it sort of flies behind you. And then it has a magic condition, which makes them look really great. If they get anywhere close to an X, it disappears. And at the end of each of the trials, it asked them how much control they had during the condition and how well they think they did. And so then there's an algorithm that controls for their perceived performance and perceived control in the normal condition where their control isn't manipulated compared to each of the individual manipulated conditions. And so with that, we compared kids with functional seizures with the matched controls that were matched on age, sex, race, and parent income. And both the turbulence condition and the match condition showed significant differences. So if you're looking at the scores here, a score of 0 would mean that they thought that they had complete control over their symptoms. And a bigger negative number means that they had more awareness that their control was being manipulated. And so here, the kids with functional seizures really believe that they had more control. They thought that they had less awareness that their control was manipulated than the match controls. So when you see a patient with functional seizures, you can have someone who has a lot of comorbidities, a lot of, psychiatric comorbidities, anxiety and depression, stress from school, learning disability, neurological comorbidities, or you can get a patient that just has FND symptoms, really, and those other things aren't present. And so we really need to be able to individually tailor our case conceptualizations and treatment to optimize care for patients with FND. So about when we were looking at the mask, the Einstein mask about predictive coding. And so this was published recently and sort of gives an explanation of this. So basically, when you see something, so basically everything that we do is based on, or every response that we have is based on a prior experience. And so instead of our minds, our brains having to take in the information, of something touching us or us seeing that and it going all the way to our brain, processing what that is, going to the other part of our brain where we decide how to respond, and then that going back out to our our mouth or our arms or our legs or whatever and responding, what happens is that we respond quickly based on past experiences. We make predictions. And so then what will happen is that we'll get an error when we respond incorrectly. We get a prediction error, and then that changes how we respond in the future. And so now the theory is that FND is an issue in this prediction and prediction error process. So for example, let's say you have only had one green apple before and it was sour, right? So you see a green apple and you think green apple sour. So when you're about to take a bite, you're prepared for it to be sour, and all of a sudden you take a bite and it's sweet. And you think, that's weird. Okay, so now I divide that into 2 things, right? So down here, instead of it just being a green apple or a red apple, now it's a Granny Smith apple that would be sour, or a Golden Delicious apple that would be sweet. And so based on that prediction error, it changes your concept of the item, and then the way you would respond to that in the future would be different. But with FND, this this is happening, something's happening incorrectly with that. So this is really similar to the learning world. I think one of the biggest problems with FND is that the language between the different disciplines is very different, and we're often saying similar things, but they don't match, right? So like when we think about CBT, we are often treating something from more of a learning model. It fits more with that than a prediction coding or a prediction error model. And so being able to sort of see how our conceptualizations overlap helps us develop better treatments that can target some of the novel aspects that are coming out in neuroscience research. So again, what I was just talking about with the predictive coding really overlaps with a learning model for FND as well. So basically, you can be conditioned where, let's say a patient who has epileptic seizures and always has like an aura or a migraine right before the epileptic seizure begins. When they have a migraine or an aura outside of that, their body can actually learn, oh man, that's a seizure, and it can produce the physical symptoms of the seizure without having the corresponding epileptiform activity in the brain that would typically be causing the behavioral symptoms of that. So that can be a conditioned response. Also, instructional learning. We know that information on TV about an outbreak of something or symptoms can actually cause physical symptoms. So when we think about mass psychogenic illnesses, a lot of times those occur in areas where there will be like rumors that they're going to use a biological weapon, like a nerve gas or something. And then all of a sudden, once that rumor has come out, you'll have a lot of patients that will present to hospitals with symptoms similar to that. But when that's evaluated, the nerve gas wasn't actually used yet. So we know that just being told that something could be occurring and that this would be the symptoms of that can create that. And then observational learning. So I believe it was like 77% of adults who've had a functional seizure have witnessed an epileptic seizure in someone else or a seizure in someone else. A lot of patients have a family member who have some kind of neurological condition. And so seeing others and experiencing the symptoms in others can also create. So again, this matches really well with that neurobiological model, but this can help inform how we retrain this with CBT. So just quickly, this was something that was gone over in the last webinar as well, but the first piece of doing treatment is being able to explain what FND is. It is incredibly important. Ideally, the neurologist or the person who diagnoses them would be able to provide this explanation, but often our patients come to us without that explanation. And sometimes they come to us without being even told that they were diagnosed with FND, even though they were sent to us with a diagnosis of FND. So sometimes and often that falls to us to be the ones to explain the diagnosis after it's been made. And so basically, FND is a reflexive involuntary response the body has learned. We develop these a lot, and it can be retrained. And so the example I give is a shrimp example. So if for lunch right now, I apologize for anyone who's eating and watching this, but if you eat shrimp today for lunch and in 15 minutes you were sick, really sick, and you vomit for the next 12 hours and you were just miserable. The next time you smell shrimp, what might happen? You feel nauseated, right? You might even vomit if you got a bite of it. And so it might not have even been the shrimp that made you sick, right? It could have been food poisoning can take 24 hours. Could have been what you had for breakfast or what you had for dinner, or it might not have been food poisoning at all. It could have been that you just got a virus that kicked in right after you ate lunch. But because those two things the shrimp and the vomiting were paired, your body actually learned the physiological response to it the next time you're exposed to it. And so we can see how this would be adaptive, right? If you're wandering around the woods a long time ago, you eat a berry and it makes you sick, you don't want to rely on your memory to like identify that berry next time, right? And so that, next time it might kill you. Next time you see it, you get nauseated and you just go away and you leave it, right? But when your body learns something that's not adaptive, that's not helpful, it can be a problem, like with the FND symptoms. However, we can retrain those, so that's good news. All right, so briefly, we looked at, and we're still collecting data on this. We haven't published it, but this is our initial, I think 38 kids and their parents, where we ask about stigma or discrimination experiences in healthcare settings. And so what we did was separate the individual, like the kids who had no history of trauma or like some other psychiatric or psychological diagnosis. So of our kids that had no abuse history, 35% of parents and 23% of the kids were told that they must have an abuse history because they have FND. So for example, the most recent experience of this was a kid who was at school and was having a functional seizure. And during the seizure, the nurse told the principal that she was obviously abused because this is what causes that. And so then the girl went home and told her mom and basically just said, was I raped? My school nurse said I was raped and I didn't think I was. And so she was like distraught and upset, obviously, which is, being told that when you don't have a history of that is traumatizing on its own. So of the kids who did not have a comorbid anxiety, depression, or other mood disorder, 70% of their parents and 60% of the kids have been told that they must have one because they had an FND diagnosis. And of those kids, 24% were actually given a medication to treat, or an antidepressant to treat the FND despite not having a mood complaint. Additionally, of our total sample, 75% of the parents and 69% of the kids reported a misunderstanding, like the healthcare provider misunderstanding their severity of their symptoms. And over half were actually told that their symptoms were fake by a healthcare provider. And so this is heartbreaking. So overall, going back to one of my earlier points, the kids with FND may have comorbid psychiatric diagnoses, and because they may have a slightly increased risk of having a comorbid disorder, we want to make sure that we assess that. And if they have it, they need treatment for that too, right? If they have a history of trauma, just like any other treatment in any other child that we treat, we want to make sure that we do a full biopsychosocial assessment. And if those other issues are there, we want to be able to either provide the treatment ourselves or be able to refer to make sure that they are obtaining treatment for that. So, the neurology assessment is really important to help identify if there's a comorbid neurological condition to confirm the FND diagnosis. PT, OT, and speech therapy are really great to help with the continuous symptoms that occur. They're not necessarily as helpful with some of the episodic symptoms because they don't see them while they're in therapy. Bottom up interventions, so habit reversal, which is one of the, I think, key pieces of ReACT that we'll talk about. Cognitive interventions, so targeting mood if you need to, or targeting catastrophic symptom expectations that we talked about. Behavioral interventions like sleep, avoidance, scheduling, motion regulation strategies if needed, learning interventions if they have a learning disability. You want to be able to do the biopsychosocial assessment and formulation for the whole family, provide good psychoeducation about FND so they'll accept the diagnosis, provide that family plan for being able to respond to symptoms, and family therapy if needed, if there are other family issues. You want them to return to social activities in school. You can provide social scripts to help them explain what's going on, why they've been out. And then interventions with other group leaders, child protective services, whatever else might come up. So most pediatric patients with FND do get a recommendation for CBT after their diagnosis. And again, this is really important, for people with episodic symptoms, that may be the only recommendation they get for treatment because, like I said, PTOT speech may not be helpful for someone who only has the symptoms episodically. And so CBT really is believed to be generally helpful for FND, but what does that mean? What is CBT, right? I'm preaching to the choir here, so we're going to go through this quickly, but there are obviously 3 waves of CBT, right? You have the behavioral CBT, classical and operant conditioning. You have classic CBT, like the classic Beck CBT, that focuses on the link between thoughts, behaviors, feelings, and how they reinforce each other. And then you have acceptance, the wave 3. So it's mindfulness, focuses on accepting painful or unpleasant sensations instead of trying to change them. And so what CBT looks like, CBT isn't one thing, right? What the CBT that you do looks like depends on what you're treating. And so for depression, we have an etiological understanding of what causes depression. So you have the cognitive triad, where you have negative thoughts about self, others, and the world. And so that's that classic Beck CBT, identifying cognitive distortions, challenging and rationalizing them, behavioral activation, behavioral scheduling, things like that. And then for anxiety, you have a different etiological model. So you have anxiety, you avoid, that makes you feel better. Then your anxiety gets better, so that continues, you continue to avoid, you feel better, the anxiety grows. And so an evidence-based treatment for that is exposure and response prevention, right? Still a CBT-based treatment, but looks different than the classic Beck CBT for depression. So we really need to develop our treatment for FND based on our etiological understanding so that we can target the mechanisms that underlie CBT and really be able to help optimize and standardize our treatments. And so this is an experimental therapeutics approach. This is used with medications a lot, but it helps translate our growing understanding of these factors that cause and sustain or maintain the symptoms into treatment. So basically you have a new discovery in neuroscience or behavioral science, then you complete the treatment and see if that treatment changes those targets. So not necessarily the FND symptoms, but the mechanisms that underlie it. And then that helps show that, we're changing that mechanism, and then you evaluate the strength of that relationship with the outcome. And so this is part of the NIMH strategic mission. So we have retraining control therapy. And so this is what we've been doing with that to be able to optimize it. ReACT is really a short-term outpatient intervention that targets FND. It's not meant to target mood or other comorbidities, although we manage those if they're present, but our ReACT is really meant to target the FND symptoms. And so they're seen weekly ideally for about an hour for 5 to 12 sessions. And it's currently the only pediatric FND treatment that has been assessed by a randomized control trial, a pilot randomized control trial, and we're working on the large efficacy study. So the targets of ReACT are sense of control, attention to symptoms, and symptom expectations. So this is what we're trying to target and improve with ReACT to improve those FND symptoms. And so we provide a clear explanation of what FND is and the treatment, which we already talked about. It provides an individualized patient plan and then a family plan to respond to symptoms, and then a plan for them to return to school and other activities. And so the patient plan really consists of 2 things. One are competing thoughts, and one are competing movements and behaviors. So competing thoughts. So instead of doing thought tracking where we teach them, what that is, we try and catch what their automatic thought is, and then over time we start working with them to challenge that. We sort of know what their automatic thoughts are typically when they are going to have an episode. So in general, it's a scared thought, like an, oh no, this is going to hurt me, this is not good. And then an expectation thought, right, of like, uh-oh, here it comes, I'm going to have an episode. And so these are the 2 things that we target in the plan. So we have calm thoughts. So the episode is going to hurt me. And we replace that with, I know the episode won't hurt me because, and we do go ahead and help them get that evidence of why do you know that, right? How many of you has it ever hurt you long term? What did the doctor say? Did you have tests done where did they confirm your diagnosis? Did they say it was going to hurt you? So we come up with calm thoughts. Then we come up with control thoughts. And so this counters the expectation, right? Here we go, I'm going to have an episode. And instead of that, I don't have to have an episode. I have a plan, I know what to do, and I can manage this. So then for the competing responses or movements, I think the key to this is habit reversal. So, habit reversal is a well-established treatment for Tourette's, for tics, and it uses competing responses to retrain automatic movements. And so the general rules that we use in ReACT for developing opposing movements and behaviors for FND symptoms is that you want to do the opposite of what your body wants you to do. So the opposite of moving is not moving. So we always say that's exactly not what we mean. We want you, if you try, your arms start shaking, you're going to try and get it to not move. It's sort of suppressing. We don't want to suppress. What we want to do is override. We want to do a different movement. Not try to not move. So we give them a different movement that's basically incompatible with what their body would do or is doing during the symptom, during the FND symptoms. The stronger the competing response, the better. So if they're in private, especially doing really big movements and doing them sooner, the sooner the better. So 98% of our kids with functional seizures reported having a premonitory symptom or a symptom where they could tell an episode was going to begin before it started, at least some of the time. And so what we have them do is sit down and start doing your plan immediately, as soon as you can. And we do want, that's the other piece. We want them to sit as soon as they know they're going to have an episode. So we want to get them, and so if they can begin doing the competing response before the symptom begins, then that's wonderful, because it's easier to prevent a symptom from beginning than trying to override it, although they can override them as well. So bigger responses, doing them quickly. And so this really helps, again, while we're talking about targeting mechanisms, we know in other neurobiological research that sense of control or sense of agency is triggered by efferent motor control or the child moving their own body. So giving them these composing responses, giving them control over that has been shown to increase sense of control, not in an FND population, but in other populations. So again, this sort of fits our model of what we're targeting. Okay, so I could give you examples of opposing responses, and at the end, if you'll have specific ones that you want me to go through, I can do that. But I think it might be helpful to hear a patient talking about what her symptoms were and what opposing responses she used that were helpful for her. So I have a sort of short video, it's about 3 minutes, about and she goes through which opposing responses were helpful for her.
So my symptoms started in January. It started as chest pain, and then from there it began with tics and kind of like seizure-looking episodes, and it affected my entire body, and I wasn't able to go to school, and I really didn't get any answers until I finally lost my memory and wasn't able to talk, and all of my cognition was gone, and then I was finally diagnosed. My symptoms were happening multiple times a day when we first started. I would say about every couple hours, and they would last anywhere from 2 minutes to an hour. They just kind of took over my existence. The most helpful part of treatment for me was probably being able to realized that I was able to control my FND. When my tremors first started, I would do the opposing response to them, which was doing large movements. Those consisted of like when I was having a tremor in my arm and I was shaking like this, to kind of overpower it and do big arm movements like that, or just kind of getting up and finding a way for me to occupy myself other ways. When I had cognition issues, a lot of times I would just do everything I could to ignore them and not question myself and have others question me as well. When I was having difficulty with speaking, or I was trying to vocalize in a different way, I would kind of override that and try to make a different noise that my body wasn't telling me to make. So if my lips wanted to buzz, I would maybe start humming so that my lips wouldn't be buzzing, but I was able to still make a noise. And that was a really big part of retraining. Once I started my plan, I was able to kind of retrain everything in about 3 weeks, but it definitely got worse before it was able to get better because it was a huge change from what I was kind of doing before. I haven't felt like I was gonna have any episodes, and overall, I feel like I am back to what I may have been before, if not an even better version of myself.
So one thing I want to point out real quick that she said was that she was able to retrain everything pretty fast, but that everything got worse before it got better. So we talk about that as an extinction burst. And that is something that we see very frequently when they start doing the plan and start, they're basically able to start like affecting the symptoms and changing the symptoms when they start doing the plan. And then a lot of the time they'll have either a really significant increase in the symptoms that they already had, like bigger, more intense episodes, longer episodes, something like that, or they'll have new symptoms altogether. And so we prepare them a little bit for that. We don't want them to expect it either, but when we do the intake, we definitely tell the parents too of like, okay, when they start doing this, you may see increased symptoms or different symptoms. That is part of this. It's a good sign. Really, it means that what they're doing is, is working. It's messing with the symptoms and it's having a response to that. Keep going, keep doing, what you planned. And so anyway, look out for that extinction burst and keep going. When you see the extinction burst, whatever you're doing is messing with it, and just plan for them to be able to keep going with that plan. All right, so we give the parents a plan as well. We give in the very first session, we give that patient plan that we just talked about. We develop that for each symptom and the opposing responses, and we have them sit when they have the episodes. And then we give the parent a plan too of how they should respond to the symptoms. So basically you want to make sure that they're not in an unsafe place and they're not hurting themselves, right? If they're in the middle of a road, they could move them. If they're banging their head on the ground, they can put a pillow under that. But in general, you want them to not touch them, not talk to them. As long as they're safe, they should get out of the eye line of the child. They can stay in the room and monitor them to make sure that they're safe, but basically get out of their eye line and allow them to manage the episode independently. And so, so the reason why this is hard. So we really reinforce how difficult this is to the parents. And a lot of times when we tell the parents this, they have this moment where they're like, oh my gosh, I was doing this all wrong. Like, did I make this worse? And no, like you were doing exactly what you should have done if your child was having a seizure and you didn't know what it was, right? Like, should have taken them to the hospital. You should keep them safe. You didn't know what this was. What you've done is exactly what I would expect a parent to do at this point. Until someone told you it was safe to not do it and you shouldn't be doing it, that is exactly what you should have been doing. And we also reinforce that, like, this parent plan is as difficult or more difficult than what the child is doing. So, the child, we reinforce how difficult it is to make your body do something opposite of what it's trying to do automatically as a reflex. But also that it is really hard as a parent to watch your child have an episode and you not touch them, you not be able to, to help them or respond to them or comfort them. But we reinforce that the reason why we do this is because once the child is able to interrupt or prevent the episode, that's when they start retraining. When they're able to do that by themselves and not need something or someone external to them to be able to retrain that, that's when they'll start seeing the decreased frequency. If they always need someone or something that's external to them to stop the episodes, they're always going to need that. So, you have, I had a patient once that said, so their premonitory symptom was that they had a headache. And as long as they could take Advil or Tylenol, they wouldn't have an episode. And so then we actually had to take the Advil or the Tylenol away. And it's like that, there's nothing wrong with taking that for a headache, but we have to help you. You're going to be in situations where you won't have access to Advil or Tylenol in that moment. And we want to be able to retrain that as a trigger if that's triggering for you. So for right now, I want you, when you have a headache, do your plan, prevent the episode without the medication. And then once that's done, you can go back, if you have a headache, and take medication to help with the headache. We don't want to be necessary to prevent your functional episode. So when the episode's over, we let them, tell them, wait until they talk to you. Then, let them get up, get some water, and then go back to whatever you were doing before. Keep that routine normal. A lot of times the patients will say, or the parents will say, well, they're so tired afterward, they have to go and sleep. And that's, I'm sure they are tired when your body, especially with prolonged episodes. I mean, I can't imagine how draining that is to have an episode like that long. But we talk about that too as a functional symptom, that fatigue afterward, and we want to help retrain that too. So being able to go back, if they're at school and they're just really, really tired or out of it, we talk about, that's the goal of going to school at that point, is to finish school, to stay at school for the day, not necessarily to be in a class and doing everything that you would at that moment. The goal is to help retrain these episodes. So the goal right then is stay at school. That's the success. And you may not be able to finish all the work that you normally would. And that's okay at this moment, as long as you don't go home, and then we increase how much work we want them to do after they're able to stay at school. So the school plan is really similar to the parent plan. If they're not having really long episodes, and they're, the goal really is for them to be able to go out, do a plan, and come back pretty quickly to be able to prevent the episodes. And so what we say is that, we say because we want them out of the eyesight of the other kids. If they can feel it coming, we don't want them to have to stay and have an episode in front of other children. So we tell them you can get up without asking and go straight into the hall and sit by the door. That way the teacher knows, you don't have to ask, they know what's going on. They can alert the nurse or another adult. They can monitor you right there. You're not wandering really far through the school, maybe not able to make it all the way to the nurse or something. They can come down and then, the nurse or whoever can come and monitor you. The rest of the class can continue what they were doing. And then the school plan sort of looks like the parent plan, then make sure they're not hurting themselves, and then just monitor for safety, but allow them to manage it independently. Other kids should not help, should go on with class, return to class afterward. Don't call an ambulance or send the child to the ER for the functional symptoms, and allow them to participate in everything. And so we write that up. We have a little, brief explanation at the top of what FND is, and then that tailored plan for the child at school. So again, those individual, family, and school plans occur in that first session. Everything after that we use, and this is why you can't buy a manual for ReACT right now. I haven't. I was for a really long time trying to figure out how to be able to disseminate this, but it's not like a lot of our other treatments that are, session 1, session 2, session 3, you do specific things. After that first session, what you do really depends on what happened over the week. Did they have episodes? Did they feel like they could control them? Did they return to school? And based on that, it's modulated. So based on those questions, it pops out the manual. So we, in the next month or so, will have the precision treatment tool available in an adaptive web app, and we'll be able to train people to use that and give access to that dashboard and all. So that's in the works. The benefits of using a precision treatment tool like this, it really helps each treatment session target the issues that they're going through. FND treatment just isn't linear, right? They have increases in symptoms some weeks, they have new symptoms, the school does something that, sets them back and has increases. And then, what do you do in between? Is they're improving and doing pretty well? And how do you, edit the treatment plan as they're improving? So this tool helps standardize and manualize it in an adaptive way still. And it really helps provide that standardization of clinical decision-making that we all have to use all the time. So we did a randomized control trial comparing ReACT to supportive therapy. Supportive therapy, we used the explanation of stress. This is stress caused by that. We want to help you identify stress triggers and talk about ways to manage stress. And so the outcomes, we found a 94% reduction in symptoms overall. 82% of our patients had full remission for at least 60 days, with 57% achieving full remission for at least 1 year. And the average number of episodes at that 1 year mark was less than 1 per month. 97% returned full-time to school and social activities. And this all occurred without changes in anxiety and depression. It was 8 sessions is what we did. So after 8 sessions, there were no significant changes in anxiety and depression, but very significant changes in functional symptoms, which again reinforces that we can really target FND symptoms directly, and we don't have to rely on targeting mood, which can be difficult. And you can have relapses in mood over time, and you're going to be stressed. So being able to empower them to be able to manage those functional symptoms, but despite other stressors going on in their lives, is really helpful. So we have some preliminary data. This is what we're doing with the NIMH trial, but looking at change in our targets, the mechanisms after treatment. So that one condition after treatment of the STROOP, the seizure word condition, significantly improved after 60 days after the treatment. And there was no change in the other 2 conditions. So, we think that this was not just a learning effect. Same thing with sense of control. We had a significant improvement in their perception or understanding that their symptoms were being manipulated after 60 days of ReACT. And this change in the turbulence condition was correlated with their change in functional seizure frequency. So this suggests sense of control may be a mechanism by which pediatric FND treatment is effective. So overall, FND is diagnosed on positive signs and symptoms. Our current etiological theories of FND are based on errors in prediction coding and not stress. Children with FND and their families have a lot of stigma and discrimination experiences in healthcare settings. We don't have a lot of research, but we think that targeting sense of control and giving them control back over their symptoms is effective. So I'm going to do another. So I've talked a lot about episodic symptoms. we use ReACT to retrain continuous symptoms as well. So like the paralysis, weakness, gait disorders. So I want to give you a patient example of what we do for continuous symptoms as well. So this was a 13-year-old male. He had missed school a lot the first semester of the year for medical problems. He had started vomiting and having migraines in the fall and just couldn't go to school. He was he was on homebound. So finally, they couldn't figure out what was going on. I kept vomiting, and they took out his gallbladder in December, right before Christmas. So in January, beginning of January, he went back to school after that gallbladder removal. And the first day he went back, throughout the day, he had progressive weakness. He vomited. It became harder to walk throughout the day until by the end of the day, he couldn't walk at all. And so by the time he got to me, he had been in physical therapy and was walking on a walker, but still relied really heavily on his wheelchair. And so what we did, like one of the examples of incompatibility and the symptoms. So he was like, he would walk with his walker and he would pick it up and be able to walk forward. But then I told him, I was like, look, I want to see how long you can just balance without holding on to your walker. So when he stood and let go, it was maybe like 5 or 6 seconds. It was really short before he would sort of like collapse and have to grab the walker again. So I was like, okay, that's what we're going to target first. We want you to be able to stand independently. And I want to make sure, you know, we're doing this, we're psychologists. I want to make sure that you're catching yourself, right? You stand there, and if you feel like you're going to fall, you go ahead and catch that. But he was doing his homework every night for an hour, and then his parents would give him an hour of video game time before bed. So we added in another hour of practice. So he would do his homework, he would have an hour of practice for this, and then he would have an hour of video game time. And so basically what we said was the first goal, I think, was 15 seconds. We want you to get to be able to stand for 15 seconds. So you have an hour of practice. Once you get to 15 seconds, though, you get to quit. So let's say it takes you 30 minutes to get to 15 seconds. You now have an hour and a half of video game time. You can use that extra 30 minutes for video game time. However, if it takes you an hour and a half to get to 15 seconds, you only have 30 minutes of video game time now. And then we went ahead and picked it. Once you get to 2 minutes, you get a Steam gift card. Steam, if you're not familiar with it, is like a website where you can download video games. And so he was very, very motivated by this. And so, yeah, so we had him balance for 15 seconds. Every 2 days, he had to increase by 5 seconds. And again, the goal was 2 minutes for that Steam gift card. So this was what we sent home with him, and this is what he brought back. So the first day, it took him 45 minutes to get to 16 seconds. So he got an extra 15 minutes of video game time. Next day, he went straight to 20 minutes, 20 seconds, 45 seconds, a minute and a half. By day 5, he made it way past his 2-minute standing and got his gift card, and then just started walking. We didn't even talk about that. He starts walking forward with his, without holding onto the walker. So they were coming from about 2 hours away, and they were paying out of pocket. And so the dad told him, like, okay, if all I have to do is like incentivize you with a video game, then I'll get you the brand new PlayStation console if you can go back to work or to school in 2 weeks and running and play soccer. And so it's a lot cheaper than Dr. Phobien visits if we keep doing this. So the kid was like, great. So we just capitalized on the walking, right? We sent him home with a really similar handout where he was walking around his living room and then jogging and then running outside. And so he within 2 weeks was back at school. He was playing soccer and had no issues. Okay, so that's it. Thank y'all. I'll start looking at some of these Q&As maybe. If you want more information, the other thing so I told you about the training for ReACT that we're hopefully going to do soon. You can go to the website and email me, and I'll add you to a wait list for that when we are ready to begin that. The other thing we're going to do is, UAB allows me to see some patients in like surrounding states with SIPACT, but for a while I could see anyone in a SIPACT state, but they've limited that. But what they're going to allow us to do, sort of break out and for me to train therapists and hire to see in those other states with ReACT. So that may also be a possibility coming up. So anyway, all of that will be updated on website, and you can email if you're interested in any of that. Okay, let's look at Q&A stuff. I don't know what the difference is here in Q&A and chat. Here, let me stop the share. All right, so I saw someone ask about a competing response for losing consciousness. So that was one I almost told you anyway. That's a common question we get. So a lot of times the patients feel that coming on. They can tell that they may lose consciousness. And so what we do is have them sit and then basically like focus on what's around them. So, and we don't want them to look at one thing. So if they just look at one thing and describe it, it can sort of like help them lose consciousness and stare off. So what we do instead is like, I want you to look around your room and either name an item, name the color, basically know what you're looking at, speak it out loud, and go ahead and move your body in some way so that, you know, you're talking, you're seeing, and you're moving to prevent the onset of that loss of consciousness. So like for me, it's like a red picture frame with flowers, brown bookshelf, whatever. And we practice that so they can do that really quickly and go through it. So what was I going to tell you? For the kids that feel like they can't, we also talk about, so they're not actually, this is a thing where the neurologist I work with tries to correct what I write a lot when I write this, that they're not losing consciousness, like, right? Like, so but they have this perception of loss of consciousness. And so basically what we talk about though is, you know, there are a lot of reasons sometimes our brains aren't encoding what happens to our short-term and long-term memory. And so if you feel like you lose consciousness, you may actually be able to remember more, even if you're confused, you may be able to remember more than you remember later that you can remember, if that makes sense. So we sometimes we'll have them, let's say they pass out and they're just sort of laying there or something, we'll have whoever's around, a parent or someone, be like, remember your plan, and give them a single prompt and sort of do that. And or if they have, like, especially if they have really short time too, they feel like they can't get to it, we'll have them do like, okay, your opposing response to keep from losing consciousness or to get out when you're confused. If you hear someone say, do your plan, one big something movement, something, one big response to be able to get out of that. And then when you start feeling less confused, you can start doing those other pieces of the plan. Okay, let me see what else.
And Erin, there are a bunch of questions in the Q&A. I know we had asked if people could submit questions in the Q&A. It's a little bit easier for us to kind of keep track of those.
Okay. So age range for ReACT, the initial study, the initial pilot RCT was 9 to 18. Now it's 11 to 18 in the research. You know, because it's such a nice mix of really behavioral things and a parent plan that like manages sick roll or secondary gain that might influence things as well. I don't think there's actually a developmental effect. There is a developmental difference in sense of control that increases over time, but sense of control, so we had to, I dug way into this for the grants. So sense of control does already begin to develop and show in young kids. And so it peaks over time, but it's already being developed in young kids. But, you know, this is probably why we see that floor effect too you really don't see really young kids with FND. You know, most often it's adolescents. We get some 9-year-olds occasionally, but very, very rarely. So I'm looking at the physical and emotional neglect, and so that wasn't labeled well, I guess. So the Macy and the Basque were the T scores. There isn't a T score for the oh my gosh, the childhood trauma, CT, childhood trauma questionnaire. So that's it's like an additive score, so it's not a T score. So there was no significant difference at all in trauma, any kind of neglect or abuse. And so my guess, I don't have that up now, but my guess is the reason why the numbers look different than or similar to the T scores would be, but I think numbers are really small. I think they're like 7, 9, something like that when it's reported. But yeah, so there was no difference in neglect. And in the paper, it shows all of that labeled specifically with what, yeah. So the numbers, I'm looking at it now. The numbers were like 9, 7, 8. So these are additive scores. And the totals, again, it's additive, but like for functional seizures, it was about 40. For match controls, it was about 46. So overall, the match controls reported higher numbers. So anyway, there was no significant difference in that, though. We haven't published the stigma paper yet. We have, gosh, now we have more. We probably have 40 something of the sample size for the stigma information, but we have a bunch of patients that are being enrolled still in new studies. And when we first publish that, I want to make sure that it's a big sample size. So that's just sort of preliminary data so far. So someone asked also about so the pilot RCT, 57% had full cessation of symptoms. So like no symptoms at all at the long-term follow-up. And so, they're asking about the other 43%. The other 43% were having less than 1 per month, and they were all back at school, every single one of them, and all back at their activities. So, ideally, we would love for them to never have symptoms again, but realistically, based on if we understand this as like a learned response, like something your body has learned to do, we know with learning that you never unlearn anything ever. And so, basically, you've learned something, we learn something else, and it will suppress the old learning, but this is where we get spontaneous recovery, right? And so there are a bunch of different reasons why spontaneous recovery can happen, but realistically, and this is an area of interest now. So in the studies that we're doing now, we're doing planned booster sessions versus, booster sessions as needed. The first study with the 57% had no booster sessions, so we didn't see them again in a year. So we're looking at ways, but it's something that we expect. But overall, all of our patients were functional and they were able to manage them. So the main outcome, I absolutely want to get to where everyone is basically has no symptoms at all. Realistically, what we want is for them to have symptoms very rarely, and when they have them, to be able to manage them quickly, stop them, and keep doing, where it doesn't keep them from doing anything. It's a good question.
Aaron, the next question was about school and how to get schools on board and increasing confidence to follow that school plan of, not calling 911 and things like that. So if you're able to speak to that a little bit.
Yeah, so most of our schools do cooperate well. We do have schools sometimes that push back pretty hard. We're lucky in Alabama. We have something called the Americans with Disabilities Advocacy Program. So basically it's a nonprofit that will work with patients and families to make sure that schools do not, basically they're following the ADA. And so, when they tell us, when they really push back, we'll eventually say, like, we'll get ADAP involved. You cannot discriminate based on this student's mental health condition. Like, we have to be able to do this. And we explain, like, you're hurting the patient, right? Like, keeping them from school is hurting them. If we keep them at home and get them better and we send them to school afterward, they're going to probably have another symptom. Like, it's just likely going to happen. And so we want to get all of that done now. But mostly, having a really comprehensive plan, we talk to the school, we listen to concerns they have, and we basically try and keep those general things that we want, right? Like, we don't want them touching them. If they are just like adamant, like, what if they're dying? Well, how many episodes have you seen? You've seen 15 of these. If they look different than that, do something else, right? But when you've seen this many of the episodes and you know what this is, it's a functional episode, treat it the same way. You really, are really worried about getting sued that much, you can put a like a pulse oximeter on them. I don't care about the oxygen level, right? We want them, if their heart is beating, they're good, right? Like, there can be variations in the oxygen level. Their heart rate is going to go up because they're moving possibly and they're anxious, but like, they're alive. Back off. The more you interact with them, the more you touch them, the worse it's going to be. We work with them too on issues like if they have really long episodes, and some schools will just let students, change classes, even if they're students having an episode in the hallway. Sometimes they'll like try to shut down the whole school until the episode's over, which just makes it all worse. If they know, they can hear that, they know that they're shutting down the school because their episode. So we'll be like, okay, if you're going to shut down the school, you put them in a wheelchair or something and move them into a private place. So just working with them, hearing them, and being really confident in, like, and when they talk about the diagnosis, like, I didn't make the diagnosis. We don't make the diagnosis, but we treat it, right? This is the treatment for it. This is what needs to do, and assuring them too that it ends, right? If you can get through this, it gets better, and it gets better pretty fast. And just sort of holding their hand, working really closely to get them to do that.
There were a couple of questions. Thanks, Aaron. That's super helpful. There were a couple of questions about kind of families who might not be on board with diagnosis or treatment, kind of how to help kind of get them on board.
Yeah. So I am coming to realize that the patients that we end up trying to help the most to try and get on board or whatever, probably just we're not going to get there. And honestly, they need to be on board and willing to do the treatment, because the longer they feel like or say that they're in treatment and they're never doing our plan at all, the more likely it is that treatment is not going to be successful there for them in the future. So I've really started getting pretty strict about, if you're not doing the plan, if you're not ready for this, if you're still looking for other diagnoses, you're not ready, and we don't need to treat you. You need to come back when you want the FND treatment, because it's only going to hurt you. It's only going to hurt your child if you're coming and not doing the plan, because you're going to think that this failed when really you've never done the treatment yet. But to try before we dump them, that's what they tell us, right? It's like, why are you dumping me? It's like, I'm not dumping you. You're not doing my plan, and you really don't like us that much. Like, at that point, right? They're generally not very happy with you. To try though to get them on board, we'll try and schedule meetings with the neurologist that diagnose them, so that they can ask those questions. A lot of times they don't feel like they were heard, or like the neurologist didn't explain why they know that this is FND. And so we try and like schedule that so that they can ask those questions, and the neurologist can really clearly indicate why they know that this was FND. We do try that, and that helps. It helps sometimes.
So I know we have a lot of other questions, but we are out of time for today. But we will try to kind of look through some of the questions and potentially incorporate some of those things into future FNSD webinars, FNSD SIG webinars. So also you can feel free to email questions to us. We encourage you all to check out our SIG website with a lot of great resources. We can actually put the address for our SIG in the chat box as well. Devin, did you have anything else you wanted to kind of say before we wrap up? I can paste that into the chat box for everyone.
Yeah, and people can email me too.
Yeah, I know there were a lot of questions about kind of some specific competing responses to use for certain types of symptoms. So those may be great questions to direct to Erin via email, if you'd be willing to answer some of those by email, Erin.
Sure, absolutely.
Well, thank you all again so much for attending, and thank you so much to Dr. Erin Phobien again for a wonderful presentation. I know a lot of us are really excited for when ReACT is able to be disseminated a little more widely.
I'm very excited too. Ready for that.
Okay, thank you again, everyone.
Bye.